Patient Jane Doe is a 58-year-old female admitted 3 months ago with a subarachnoid hemorrhagic stroke. Consequently, she is experiencing significant neurological compromise and altered levels of consciousness. Jane has a history of hypertension, dyslipidemia, and type 1 diabetes mellitus. Jane is currently in a prolonged recovery stage but is considered stable. She's impacted by diminished independence and quality of life. Jane's current experience is being defined by neurocognitive decline, complete dependence on medical care, and nasogastric nutrition. Her partner has remained bedside for the duration of her admission and acts as a primary caregiver. From a nursing perspective, this case requires a holistic approach that balances medical intervention with compassionate care. Our subjective cues are impacted by Jane's altered level of consciousness, making verbal articulation of cues impossible. As Jane's partner and caregiver, Mary is familiar with Jane's baseline behaviors and reports that Jane has recently had an increase in grimacing, which seems to coincide with elevated blood sugars. In this scenario, objective cues refer to the measurable and observable clinical data that provide insight into Jane's current health status. These cues are gathered from lab tests, vital signs, and physical assessments rather than subjective reports of symptoms or discomfort. Specifically, they include elevated blood glucose readings, elevated serum glucose, elevated hemoglobin A1C, decreased sodium, elevated triglycerides, and tachycardia. Above are generalized head to toe and considering her history of subarachnoid hemorrhage, neurological compromise, and altered consciousness levels, a detailed neurological assessment, neurovitals, and Glasgow Coma Scale is a priority to monitor for changes to that system. Additionally, due to her type 1 diabetes, we would want to assess her blood glucose. Typically, blood glucose monitoring is done before meals, but due to her nasogastric feeds, her readings are scheduled every 4 hours. So why are these cues important? Given her history of type 1 diabetes mellitus and subarachnoid hemorrhage with neurological compromise, elevated blood glucose, serum glucose, and hemoglobin A1C reflect poor glycemic control, which can increase neuroinflammation and cerebral edema post-hemorrhage. Elevated triglycerides can indicate metabolic derangement, possibly compounded by NG feeding. Decreased sodium may be linked to hyperglycemia-induced osmotic shifts, exacerbating fluid imbalances and cerebral complications. Finally, neurological injury can impair the autonomic nervous system, leading to dysregulated metabolic and cardiovascular responses. Analyzing our cues. We are most concerned with Jane's chronic elevated blood glucose as it can worsen neurological outcomes, increase the risk of infection, and delay wound healing. It can also contribute to fluid imbalances and autonomic dysfunction, which are all compounded by her history of brain injury. Hypotheses. Hypothesis 1, hyperglycemia or uncontrolled blood glucose, as it clinically manifests with elevated blood glucose, serum glucose, and hemoglobin A1C, elevated triglycerides, and decreased sodium. Hypothesis 2, hyperosmolar hyperglycemic state. The cues that support this hypothesis include increased blood glucose and serum glucose, increased triglycerides, and decreased sodium. Additionally, tachycardia and altered level of consciousness. Rationale for dismissing hypothesis 2. We have chosen to dismiss hypothesis 2 because HHS is more common in type 2 diabetes and manifests with significantly elevated blood glucose at minimum above 30 millimoles per liter. Decreased sodium in HHS is associated with significant osmotic diuresis and dehydration. The patient does not exhibit signs of either of these. The altered level of consciousness that is observed in our patient is directly related to hemorrhagic stroke or brain injury. Finally, an elevated hemoglobin A1C shows chronically elevated blood glucose levels, whereas HHS is associated with an acute elevation. Rationale for choosing Hypothesis 1. We have chosen hyperglycemia as our priority hypothesis because the cues exhibited by Jane, such as elevated blood glucose, serum glucose, and hemoglobin A1C, confirm that Jane's blood glucose is not only elevated, but has been chronically uncontrolled over the last 2 to 3 months. Additionally, her elevated triglycerides, hyponatremia, and tachycardia further indicate metabolic disturbances linked to hyperglycemia. We are concerned about hyperglycemia in relation to type 1 diabetes as evidenced by increased blood glucose, increased hemoglobin A1C, and increased serum glucose. Generating solutions. Solution 1. Within the next 24 to 48 hours, stabilize Jane's blood glucose levels to a target range of 6.0 to 10.0 millimoles per liter by consistently monitoring blood glucose and through insulin administration. Solution 2. Within 12 to 24 hours, promote nutritional and metabolic balance through the provision of internal feeds that support the patient's unique nutritional and metabolic needs. Taking action. First, the nurse will check capillary blood glucose every 4 hours using a glucometer. The nurse will then administer insulin as ordered and use blood glucose readings to determine any necessary correction doses. Second, the nurse will collaborate with the dietitian to ensure the nutritional plan aligns with the patient's metabolic needs and minimizes unnecessary glucose intake. Before each feeding, the nurse will confirm that the formula meets the patient's current nutritional requirements. Finally, at the start of each shift, the nurse will verify that the continuous nasogastric feeding is running at the prescribed rate to prevent postprandial glucose spikes. Continuous feeding helps maintain steady nutrient absorption and stabilize blood glucose levels by preventing sharp fluctuations due to rapid absorption of liquid nutrition. Did it work? At 24 hours, the patient is actively receiving and tolerating enteral nutrition tailored to their metabolic needs with stable blood glucose. At 48 hours, through nurse observation and caregiver input, the patient will demonstrate a reduction in signs of discomfort such as grimacing. Blood glucose levels are within target range of 6 to 10 millimoles per liter with no hypoglycemic events observed. A long-term goal of 3 months is a reduction in hemoglobin A1C to below 7 millimoles a liter, indicating optimal long-term blood glucose management for a patient with type 1 diabetes. Although this is a long-term measure, it will reflect the effectiveness of ongoing interventions if maintained. Discharge planning. Discharge planning looks different to everyone. Some people are being discharged home, while others are transitioning to a different level of care. In Jane's case, her and her partner Mary have a long road ahead. Since Jane will be fully dependent on a caregiver, assess the caregiver's capacity and willingness to participate in the patient's care. Education for the caregiver. Provide education focused on blood glucose monitoring, insulin administration, and managing the nasogastric tube feeding. Educate the caregiver on NG tube care, including proper maintenance and troubleshooting. Educate the caregiver to recognize signs and symptoms of potential complications that require immediate action, such as change in glucose levels or signs of infection. Collaborate with a transition liaison and social worker to determine the needed support services, such as home care or, if appropriate, long-term care. It is yet to be seen whether Jane's path leads home or to a higher level of care in a facility that can support her needs.